Hello everyone, Assalamu alaikum wa rahmatullah. Today, inshallah, we will cover very important topic and it's a recent recall. So we need to cover well in our preparation. It's enhanced recovery program. And we do have two scenarios in the exam. One of the scenarios regarding the enhanced recovery program for the patients who will go for any gynae surgeries. The other scenario related to the enhanced recovery program in or with the cesarean section. So today we will discuss the enhanced recovery program with the gynae surgeries. And to know everything about this topic, we have to go through the TOG article. And it's a very nice TOG article, but it needs like a little bit to have like a summary for that. So it will be easy in the exam or before the exam to prepare. So let's go directly to know how to speak up in the exam. I know that most of you are expert in dealing with the patient pre-operatively if the patient will go for any surgery. And also, you know, most of the points we have to fulfill in the enhanced recovery program, but how to speak up in the exam and how to speak about this topic. So what about the enhanced recovery program? We need to give introduction, and usually it's either the introduction or the definition or both of them. So enhanced recovery program pathway, it improves the quality and experience of care for patients undergoing elective gynecology surgery. What about the aim of that? It enables the patients to recover more quickly, leave the hospital sooner, and also to return back to normal life, back to work as soon as possible. Enhanced recovery program, it will reduce the physical and psychological stress on the patients, and we will know how to do that. And also it has a better outcomes. We can give the enhanced recovery program another name like the fast track, rapid, or accelerated recovery program. And it's a combination of the evidence-based elements to give the care for this patient, which will facilitate more rapid recovery, short hospital stay, and return to normal life because it will reduce the stress and the physiological stress response pre-operative and post-operative. My advice usually, if you want to revise the enhanced recovery program in one slide, it will be this one. So this nice picture from the TOG article, it's very important, guys. And it's more than enough. Just go with the points and then expand it. Just add your way in that. Just to explain to the examiner what is the meaning of this or what is the meaning of each point. So at the start, tell the examiner that the enhanced recovery program has to start from the referral from the primary care, from the GP, by optimizing the patient condition. For example, patient with bleeding and she has anemia. So we need to optimize her condition. We need to optimize her hemoglobin level. Any patient with pre-existing disease like diabetes, hypertension, cardiac patient, we need also to optimize her condition to have a good control over this condition pre-operative. So this is from the GP referral. What you will do in the pre-operative, and usually this will be done in the pre-op assessment clinic. We need to optimize the health or medical condition if not done by the GP. We need to have informed decision making. And usually it will be, you can do that by offering the patient a good counseling. Tell her about everything. What about the procedure? Or the surgery, the steps, the complications, and what about her hospital stay? What will be done for her? Even what is new here in this TOG article, the discharge date. So in the pre-operative assessment clinic, you have to tell the patient you will come on that day and you will be discharged on the same day, next day, or you will stay with us for 2 to 3 days, for example. They found that when the patient is aware about her discharge date, this will reduce the stress and also it will lead to quicker recovery and shorter hospital stay. Pre-operative therapy instructions. If we have any pre-operative preparation or any treatment pre-operative, please give the patient clear instructions about it. Give the patient all the information in two ways, verbal by counseling, and by the end of the consultation, don't forget the patient information leaflet. So in verbal way and written as well. What about the admission or perioperative? So admission on the same day. So the patient, they found that when you will ask the patient to come on the same day, this will reduce the dehydration, reduce the starvation, and also reduce the stress. So admission has to be on the same day of the surgery. Optimize fluid hydration. Allow the fluid intake up to 2 hours before the surgery, preoperative, very important. Carbohydrate loading or the complex drink, it's very important also to allow it up to 4 hours preoperative. And also they found that it will lead to less starvation and also better outcome. Reduce the starvation by allowing food and drinks up to 2 hours, and for the carbohydrate up to 4 hours. No or reduced oral bowel preparation. So in the past, some of the gynae surgeries, some patients, we have to offer them bowel preparation. Nowadays, no, it's not recommended because they found that the complications will be more if you will offer the patient bowel preparation, except, and even you can add this point because it will be individualized. For example, patient with a cancer, and you suspect bowel involvement, and the bowel surgeon will be with you because we may need to offer resection of part of the bowels or anything. What we will do at that time, at that moment, here bowel preparation is necessary. So we need to offer, and the instructions will be given by the bowel surgeon. So this is on the day of admission. What about intraoperative? Intraoperative, it's related to what about the surgery, the way of the surgery? Is it open or by the laparoscopy? And it's better to be minimally invasive. It means by laparoscopy. If it's open, as small as possible skin incision. Don't forget to give antibiotic before the skin incision, and also VTE risk assessment to be done for this patient. We need to use the transverse incision instead of the midline. It's better. And avoid the nasogastric tube, and use, regarding the anesthesia, use the regional blocks, epidural management. It's better than the general because it will lead to less opiate usage after the surgery, post-operative. So the patient can reduce the dose of these opiates with all the side effects like respiratory depression, or sometimes the patient will be dizzy, cannot mobilize early, so it will affect the early mobilization of the patient. Optimized fluid management and individualized goal-directed fluid therapy. One more thing here, intraoperative, it's not in the picture, but it's in between lines in the talk article. Avoid hypothermia, because they found that the hypothermia will lead to complications and the outcomes will not be good like when we will avoid it. So avoidance of the hypothermia improve the outcome or improve the outcomes. What about the post-operative? I think most of you will memorize this by heart or memorizing this by heart. So planned mobilization, rapid hydration, appropriate IV therapy, no wound drain, avoid any drain as much as you can, no nasogastric tube, catheters to removed early. However, it's safe to send the patient with indwelling catheter for 2 weeks if needed. For example, patient with urine retention post-operative, what you will do, you will keep the patient for 2 weeks in hospital? No, we can insert indwelling catheter, send her to home under coverage of antibiotic, and don't forget to tell her about the catheter hygiene, how to take care of the catheter. Ask her to come back as outpatient to have a trial without a catheter. And then if it was successful, you can remove it. Regular oral analgesia, and it's better to use the simple ones like paracetamol, non-steroidal. Try to avoid the opiate because it will make the patient strict to bed because of feeling dizzy or some fainting attacks because of the effect of the opiates or the morphia. What about the follow-up plan? Follow-up, we will discharge this patient when the criteria are met. What about the criteria? The patient can eat, drink, mobilize, pain controlled with a simple painkillers or analgesics, and she can pass flatus or she can open her bowel, and the catheter removed. Therapy support, and don't forget to give her 24/7 contact number, okay, for the follow-up. So this is the picture and how you can, with this only pathway, to revise all the enhanced recovery program. Okay, we can go through some some slides from the TOG article, not only the picture, but it's almost the same. You can find like little information added in each slide, but if you want to depend on just the picture, it's more than enough. Here again, the pre-operative assessment start from the GP referral. And also we will do it in the pre-admission clinic or the pre-operative assessment clinic. We have to give the patient verbal and written patient information to help the patient to take the decision, to be informed decision by the end. Pre-operative patient education also will reduce the need of the pain relief and improve the patient experience during the hospital admission. What about the date of the discharge? It has to be clearly planned and also give the patient some responsibility. And by the end of this TOG article, in the conclusion, they found that when you will change the role of the patient from the passive rule, the sick rule, into active rule, this also the aim of the enhanced recovery program, and it improves the outcome. Perioperative, on the day of the admission, we need to admit the patient on the same day. What is the advantage of that? So this is the extra points you can add over or on the picture or the pathway. Reduction of the bed usage, and it's very important from financial point of view. So if there is a bed used in the hospital, it means for the NHS this is money, okay? So from financial point of view, we need to reduce the pre-operative bed usage. Dehydration will be less. Use of the complex carbohydrate also will reduce the length of the stay and also improves the outcome. Mechanical preparation, it's better to be avoided because they found that it will lead to more morbidity. Associated with morbidity, no evidence that it improves the outcome. So it's better to avoid. Long-acting sedative pre-medication, better to be avoided because it will impair the post-operative mobility. Antibiotic prior to the incision. Venous thromboembolic prophylaxis if needed. So we will do or we will offer the patient VTE risk assessment. And if the risk is there, so we can offer the patient venous thromboembolic prophylaxis. Abdominal incision as small as possible. Nasogastric tube, abdominal drain, vaginal drain have little benefit and should be avoided. Routine use of vaginal packs has been questioned, so better also to be avoided. Avoid hypothermia to reduce the post-operative complications because they found that hypothermia related to post-operative complications. So we need to avoid that. What about the anesthesia? The spinal, epidural, regional block is better. And why? It will reduce the opiate requirements, allow more rapid return to the oral fluid intake. So we will avoid the dehydration, improve patient satisfaction, and rapid return to work. So 4 advantages here for the of the spinal, epidural, or regional over the general anesthesia. Post-operative, early feeding, remove all the tubes, early mobilization. So early feeding and reduction in the volume of IV fluids, it will lead to reduction in the nausea, higher patient satisfaction, shorter hospital stay, and also higher patient satisfaction again observed. Early mobilization, this is the key to the enhanced recovery program. And we should achieve this regardless the age of the patient. So don't say this is very old lady, frail lady, we will leave it like we leave her in bed. No, regardless the age of the patient. Encouraged by effective analgesia. So we can give the patient a good painkillers just to help her to get out of the bed. Okay, and this will reduce the risk of VTE, reduce the risk of muscle loss as well. Antiemetics, we can use post-operative, also laxative to prevent the constipation, catheters, drains, vaginal packs, IV drips, IV lines should be removed as soon as possible. And if we have any patient with short-term voiding problems, it's safe to send her with a catheter to home. Look here to this paragraph. We will offer her indwelling catheter under coverage of antibiotic, bring her back to the clinic for a trial without a catheter. If it's successful, okay, remove the catheter, discharge her back to the community. If we have a problem, you have to leave the catheter for another 2 weeks and involve urologist in her management at that time. Discharge, we need to offer the patient the time of the discharge in the pre-operative assessment clinic. And once the criteria are fulfilled, we have to discharge the patient. What about the criteria? The patient are mobilizing, eating, drinking, passing flatus, and their pain is controlled with the oral analgesia. We need to give her the written information on discharge. You have to give her the red flag signs. You have to give her the contact number, when to contact you, when to come to the emergency department. And don't forget the discharge letter, 1 copy for the patient, 1 copy for the GP, and 1 copy to be kept in the file of the patient. Patient involvement, it's very important, and it's now a crucial point in the enhanced recovery program. So we need to involve the patient and their carers at every step of the process. But their carers, if there is agreement from the patient to involve the carers as well. And empowering the patients to take a significant role instead of the passive rule, the sick rule of the patient. This will increase the satisfaction, reduce the stress, improve the outcome, make the hospital stay shorter, and make the patient back to normal life more quicker. So that's all for today. This is all about the enhanced recovery program. I will try to make another short video regarding the enhanced recovery program in the cesarean section. There is some points like similar to the points here with the gynae patients. In the cesarean section, just little changes we can apply, but this scenario is the main scenario, and this is the TOG article we have. So I wish this was clear and it was beneficial for everyone. Thank you for watching, and Assalamu alaikum wa rahmatullah.